Good evening, friends from near and far. Welcome to our Monday night travel chats. I'm Elizabeth, one of the global travel team nurses. If this is your first time joining us, I come on usually each Monday night and we talk about something in terms of topic. It is different each night, but I do try to focus on your questions and weaving those questions into the presentation so that we can all learn something and have that opportunity to get questions answered. So while we wait for people to jump on, I'm from the global travel team. So we are the special people behind the curtain that do a lot of the cycle management for you if you are going to be coming to us from outside of proximity to one of our offices. So Albany, Syracuse, Buffalo, Rochester, Colorado, Atlanta, those are all of our offices where if you're near one of those offices, you can do monitoring in them and then look to do your procedures in one of our main clinics, which are in Syracuse, Albany, Buffalo, and Colorado Springs. And so if you live outside of one of those regions, then you can do all of your monitoring at home at your local OBGYN, radiology facility, hospital, etc. And our team helps to manage all of that process until you get to us in one of our offices in New York. And so tonight we're going to talk all about protocols. So we get a lot of questions about medication protocols, how they're determined, what each individual medication does or kind of what it means to be on a certain medication. So we're going to talk about that. We're going to talk about how the medication protocols are determined. And we're just going to look at some of the overall factors that go into play. So welcome to everyone joining us, Barbara, Jesse, Ty, Tila, Shannon. I really appreciate you guys hopping on with me tonight. And so let's get started. So you're going to have your initial consultation with one of our providers. And during that call, the provider is going to gather a lot of information from you. And that information is what is helping to determine what your medication protocol is going to be. And so some of these factors or things that influence what your protocol is going to be are things like your history, your medical history. Some of the medications that are used, they aren't indicated for everybody. So there are some clinical contraindications to certain medications. For example, history of cancer. Sometimes we won't use growth hormone. History of a soy allergy. We're not going to use intralipids. And so there are multiple different medical history factors that determine what your protocol is going to be. So that's your medical history. Your age is going to play a big factor. We know we can overcome a lot of things, but our reproductive age is a huge influencer in terms of our prospective outcome or what we think the success rate is going to be on a given cycle. A lot of that is unfortunately tied to age. So age, medical history, prior cycle attempts. So have you tried a letrozole IUI cycle at a previous clinic? How did it go? How many follicles did you make? That type of information can be really, really helpful to the provider who you're going to be doing your consultation with to determine, okay, letrozole worked really well for her. Let's make sure we incorporate that. So here in a few minutes, we're going to talk about, I'm seeing lots of questions about the differences between HCGLH and Menopur. Why do some people get letrozole added, et cetera? So we're going to talk about all those things at some point here soon. So prior cycle attempts and what those outcomes were, your medical history, your age, your AMH level, if we have it, is going to be a piece of the puzzle. If you have a very high AMH level, AMH stands for anti-Mullerian hormone, and it's a good indicator of what eggs you may have in reserve. So the higher the level, the idea is that there's more eggs in reserve. Now, too high of a level is not always a good thing because that's oftentimes indicative of something called PCOS, polycystic ovarian syndrome. And so high AMHs can be linked to poorer egg quality, a more difficult time stimulating, et cetera. So that's going to definitely be taken into consideration. And then if we have access to what your antral follicle count is, that's your how many follicles are there upon an ultrasound investigation of the pelvis, how many follicles are there without any stimulation. That's your antral follicle count, typically determined around cycle day 2 or 3, early in the cycle. This is a good indication of what the outcome may be. So just because we see 30 follicles at baseline by no means that we're going to get means that we're going to get 30 follicles at retrieval or 30 eggs at retrieval, but it helps give the provider a big picture overview of what to expect in terms of, or what may be needed in terms of medications to successfully stimulate the ovaries. So those are kind of the protocol underlying determining factors behind how we're going to develop what your protocol is, how we're going to determine what your protocols are. So most protocols, and we're talking primarily here about IVF protocols. We'll talk very briefly possibly about, medications that might be taken for transfer, but in general, this discussion is going to be about the medication protocols needed to stimulate the ovaries for an egg retrieval. So if you have specific questions kind of outside of that, I'll try to get to those at some point. So most of the IVF protocols are going to consist of a decent amount of medication. So there's going to be usually about 5 base medications that are going to be needed. And we're going to talk about each one of them, and we're going to talk about what they're used for, what their names are, etc. So the first and the biggest medication kind of out there for IVF stimulation is going to be an FSH injection. And so FSH stands for follicle stimulating hormone. And this hormone is naturally secreted by your brain. Your pituitary gland dumps out FSH in an attempt to stimulate your follicles, follicle stimulating hormone. And so that follicle stimulating hormone that comes from the pituitary in the brain is only really capable of growing 1, maybe 2 eggs a month. And so that FSH from your brain goes like a messenger to your ovaries and says, okay, time to get busy. Let's grow a follicle. That follicle then develops towards maturity. As it gets close to maturity, or as it makes steps towards maturity, it's going to start secreting estrogen. And then once that follicle gets to maturity, the brain signals to the ovaries and says, okay, here comes another messenger. It's called LH. And that messenger is a signal to the ovaries that it's time to ovulate or spit that follicle, or that egg out of the follicle into where the tube can pick it up, bring it down, get it fertilized, make an embryo. And so that's your LH. And then once that follicle does ovulate, then it secretes progesterone to help support the growing pregnancy. So Gonal-F or Follistim, those are the 2 primary injections that we use for stimulation. They contain FSH, and that FSH is an adjunct to the FSH that your brain is secreting to support the growth of those follicles. And so depending on what your medical history is, what your AMH is, how old you are, previous cycles and their outcomes, that's going to help the provider at your consult, your new patient consultation, or even in a follow-up talk, is going to help that provider to determine what is the best amount of Gonal-F or Follistim that we're going to need in order to develop the whole crop of eggs that are there. And so Gonal-F or Follistim are going to typically be supported with another medication, and we use either Menopur or HCG-LH. So it's a weak HCG, but the idea behind both of them, either the Menopur or the HCG-LH, I can't say that I've seen anybody use both. So it's typically an either or situation. But the idea behind that is to support the follicular growth and to support the LH needs of the follicles so that they can mature. And so that's the kind of component that comes from either the Menopur or the low-dose HCG. So your protocol is going to be Gonal-F or Follistim, HCG-LH, or Menopur. And then everybody's going to need something on hand to essentially prevent the body from ovulating on its own. So as we talked about earlier, the body is used to maturing and ovulating 1, maybe 2 follicles a month. However, because we're going to be hyperstimulating, it's called controlled ovarian hyperstimulation. So because we're going to be hyperstimulating the ovaries, that your body, so remember the signal LH is going to want to start dumping out as those follicles get bigger so that the ovaries can sort of go back to normal after they ovulate. And so in an IVF cycle, you will need an antagonist medication, which basically keeps the body from ovulating on its own so that we're kind of in control of the entire process. Those two medications are going to be either Cetrotide or Ganirelix, and those are both injectables. They're going to be introduced into the stimulation process, usually between stimulation days 5 and 7, most often day 6, but it is a determination based on your age. Again, all of these previous attempts, if you have known short cycles, which means let's say you get your period every 26 days or every 24 days, that tells us that we have a shorter window essentially to prevent ovulation than we do if you have normal 28-day cycles. So that antagonist medication, which is either going to be the Cetrotide or the Ganirelix, that is going to be used to prevent ovulation. So to put the brakes on ovulation while we continue to grow those follicles to a size that will be mature and that can be inseminated in the lab. So Gonal-f or Follistim, low-dose HCG or Menopur, and then Cetrotide or Ganirelix. Those are kind of your three staples of the IVF stimulation process. It should be noted, as we said kind of before, the Ganirelix or the Cetrotide, we never want to start too soon, or you would never want to start it without being advised to do so, because if it's started too soon, it can actually slow the follicle development down. And obviously, if it's started too late, then we can lose that window and you can have some ovulation. Usually if that happens, you don't necessarily lose all the follicles, although later in the cycle, if you miss a dose of Cetrotide, that really can be the difference between early ovulation or late. So Adalia asks a great question, which is, how would that affect someone with a 34-day cycle? So that's a great question. So if your cycles are a little bit longer, then we might not be surprised if you stimulate a little bit longer. Not always, but it can mean that we're going to want to be careful. As I mentioned, it can slow growth down if it started too soon. And so that would be just a matter of keeping an eye on your LH levels and making sure that we do some frequent monitoring. And that's why we do monitoring, the way that we do. So you do your baseline and then usually go back again around day 5, 6, or 7, and then every other day until it's time to trigger. And so that's a great question. And the answer is really that in your case, we would be looking more at LH to see if that is on the rise and incorporating that into the process. So the next question before we move on, this is a great question. So is there a lab that can show if ovulation is about to occur? Yes, and that is LH, Felicia. Excellent. And so LH, again, that's that hormone that your brain is secreting to the ovaries to say, okay, now it's time to ovulate. And so if you go back on, let's say, stimulation day 5, let's say your baseline LH was 4 and now it's 16. That's a good indication that we ought to get your Cetrotide started now to prevent your body from naturally going into that ovulation process. So that's an excellent question. Okay, so Gonal-f or Follistim, low-dose HCG or Menopur, and then your Cetrotide or Ganirelix. And those medications are going to carry you to your trigger. And so everybody is prescribed 2 medications for trigger. And there's a very good reason for this. And I get this question a lot is, well, I see that I looked at my med list and I have 2 triggers. Why do I have 2 triggers? So HCG is kind of the standard trigger for IVF. So HCG, when injected, causes your body to enter, tells your follicles, okay, it's go time. I need you guys to get ready, get mature, and be available when we go for the egg retrieval. And so HCG, though, is something that can actually flare the ovaries after retrieval to where you develop something called ovarian hyperstimulation syndrome. And so unfortunately, we don't know until it's trigger day. Now, if you have an AMH of 15, it's probably a pretty good indication that you're not going to need HCG for trigger specifically. However, as you know, I mentioned before, we want everybody to have a dose of HCG, 10,000 units. That can be substituted with Novarel, human chorionic gonadotropin. So that's just the generic form, or there is a medication called Avidrel. Typically for IVF, we want you to have 2 of those and not just 1. But that is the HCG that's used for the trigger. So if it's not used for the trigger for any number of reasons, and those reasons are primarily if you are at high risk for ovarian hyperstimulation, your estrogen in the stimulation cycle is high, that's going to be an indication we're probably going to hold the HCG, and then it can be used for the transfer itself. So it doesn't go to waste, but it is something where we have to always take into consideration your safety, and that's sort of what determines whether or not the HCG is used. But again, if we find that we need the HCG, so typically with very low estrogen levels, if you're somewhat of a poor responder, if you have a low AMH, if you're reproductively older, those can be indications that within the absence of HCG, we won't get good maturity. So of the follicles that we aspirate and pull an egg out of, that egg may not be mature, may not fertilize. And so if you don't have HCG and you need it, that can be quite detrimental. And so I 100% respect the idea that this is all very costly process, and we want to save as much money as we can anywhere that we can, but not getting a medication that's ordered for you can be really detrimental to the cycle outcome. So everybody needs to have on hand, unless you were told specifically otherwise by the provider, the HCG for trigger and Lupron. So Lupron is another medication used for trigger. It tells that follicle, get ready, release the egg so that it's free floating in the follicle so that it can be retrieved at retrieval. Also tells the follicle tells the egg inside to enter its final phase of maturing. And so Lupron will be used exclusively if it's determined that your estrogen is high or you're at a very high risk for the ovarian hyperstimulation syndrome. So we're able to really mitigate against severe OHSS by triggering with only Lupron. And so if you trigger with only Lupron, then chances are we're expecting a pretty high yield of eggs during your retrieval. And we're probably looking at doing a frozen embryo transfer, because what is the hormone that we test for in pregnancy? It's HCG. And so that HCG, whether it comes from trigger or whether it comes from the resulting pregnancy from a fresh embryo transfer, that HCG either way will cause the ovaries to flare. And so if you are at high risk for ovarian hyperstimulation syndrome and you use the Lupron only, there's a pretty good fair chance that you're not going to be looking at doing a fresh transfer just because of that resulting HCG. So those are the primary 5 medications that are going to be needed in any protocol. The amount of said medications is going to be individualized to you. And those factors that we talked about in the beginning, which are reproductive age, antral follicle count, medical history, prior cycle attempts, all of those things are going to be a sort of determinant of how much of a specific medication we might prescribe for you. So if you have a relatively good AMH, you've got lots of nice looking follicles, you might find that your protocol looks something like 250 or 225 a day of the Gonal-f or Follistim, and then 20 units of the HCG or maybe 75 units of the Menopur. Whereas if we know there's some diminished ovarian reserve, or you've had a previous cycle that we used that amount and it didn't yield you as many, then that might be an instance where your dose might be something like 300 or 450. And so, like I said, those medication dosage amounts are determined by the provider as a result of all of those factors that we kind of talked about. So in addition to the 5 medications, so again, the FSH, which is the Gonal or the Follistim, the low-dose HCG or the Menopur, the antagonists, which is the Cetrotide or the Ganirelix, and the triggers, there's also letrozole. So that's number 5. That's the number 5 medication that's often included in medication protocols. So letrozole assists in the growth of follicles and is introduced depending on your AMH. Again, all of these factors that we talked about are going to help determine whether or not we use letrozole. Letrozole does sort of block the estrogen levels in the blood. And so if you use letrozole and you look on your patient portal and you see, oh my gosh, I'm stimulation day 8 and my estrogen's only 100. I read, on, a website that's not good. Keep in mind that letrozole is going to inhibit the estrogen levels in the blood. And so it's not uncommon at all for us to see situations where estrogen is very low and we still get a wonderful outcome. And so letrozole is a medication we're using more and more for the most part. Some people they don't have the best response to letrozole, but for the most part, it is something that can help a cycle, and it can certainly be one of those factors where we can always add it in if we determine that it's needed. Sometimes we actually use the letrozole to help prevent the estrogen from getting super high. So those are the 5 primary medications. And then on top of those are going to be what we call the adjunct medications. And these are different medications that serve a different purpose in the cycle. Most people are going to get 4 pretty standard sort of adjunct medications. And those are going to be prednisone, and that's a steroid that you take orally. It's typically taken twice a day, and it just helps to prevent, it helps to quell inflammation in the body. And we know that inflammation is toxic to the development of eggs and in pregnancies in general. So prednisone is a good, pretty standard medication. Obviously, or not obviously, but there are going to be contraindications to steroids. And so not everybody may have prednisone, but it's a pretty common adjunct medication that we use in most cycles. On top of the prednisone, there's another medication that we use pretty frequently, and that's the low-dose naltrexone, or the LDN. That medication is a really powerful anti-inflammatory and immune modulator. So it helps to prevent your immune system from interfering in the body's processes as we go through. So oftentimes our immune systems are overactive and they interfere with the process. And so the LDN kind of helps to level all of that out so it doesn't interfere in the process. Everybody will be prescribed prenatal vitamins. And so if you're not taking those already, you definitely should be. And those are just your basic vitamins and minerals that are needed to support a healthy pregnancy. And so everybody should be on a good, high quality prenatal vitamin. And then most of you are going to be prescribed some form of an antibiotic. And that would, of course, be dependent on if you have any allergies or things like that. But most of the time we prescribe a Z-Pak. And that's just to prevent bacteria from the retrieval itself or the transfer, even an IUI, from making its way into the uterus and causing an infection. Even if it's a subclinical infection, it can cause a situation where we don't get implantation, or you get an infection in the pelvis. So we want to avoid that. And then one of the other more popular adjunct medications that you might see in your protocol is human growth hormone. It's known by the brand name Omnitrope, and it serves to accelerate the maturing process of the eggs themselves. It also helps to improve the quality of the eggs. And so you might not see a human growth hormone involved in your cycle if this is your first cycle, if you're reproductively young, any of those things. But it can be a really great adjunct if you've had trouble with egg maturity. So let's say we bring you to a retrieval, we are able to harvest 15 eggs, but of those 15 that we collect, only 5 are mature. That might be a good time or good indication that some Omnitrope taken. Not only can Omnitrope be taken through a priming phase, which is typically the month, 2 months, or 3 months leading up to the stimulation cycle, but also during the stimulation cycle, that growth hormone is serving to help with the quality of the eggs and their overall maturity. So those are the primary adjunct medications. And then we have, for any of you who've been with us for any length of time, you know that we use a lot of immune medication. So as I was talking about the LDN is a really powerful medication used to regulate the immune system. And we know that immune issues, even if you don't test positive on any sort of immune blood testing, on any obvious ones, we do know that immune issues can interfere and inhibit successful retrieval, ovulation, all of those things can be really affected by whether or not that is present. And so that's another good indication that immune medications might be helpful, is if you've had some issues with failed cycles for not a great known reason. You might see that there's going to be some immune medications brought into play, because as we continue to grow in this science, in this field, the more we realize that the immune system plays a critical key role in your overall outcomes. Of the immune medications, some of the ones that you might see in your protocol, intralipid therapy. So intralipid therapy is primarily used to suppress natural killer cell activity in the uterus. Oftentimes, we introduce intralipids. Again, if you have a positive natural killer cell antibodies, if we do a blood test, then that's a no-brainer. You're probably going to be prescribed intralipids for 12 weeks of pregnancy, because we know that those natural killer cells can play a negative role in an early developing pregnancy. But maybe you're hoping to throw a reasonable amount of things at the process, and you want to try intralipids, as long as there are no contraindications clinically, then that's something that you'd be free to add on. So there's a number of different reasons that intralipids may or may not be integrated into your protocol. Another common immune medication that we use a lot is the Lovenox. So that's a part of a few of our immune protocols. And that can help with underlying blood clotting disorders, even ones that we don't necessarily know are there. So again, you may test positive for the number of different blood clotting disorders that we might look for and still be on Lovenox. And the question is why? The answer is primarily because we know that tiny microscopic blood clots can cause implantation failure. It can cause early miscarriage. And so the Lovenox serves to prevent those microscopic blood clots from interfering negatively in that early developing pregnancy. So I oftentimes use the example that a placenta is like roots of a tree. And those roots are burrowing into the uterus, but on a very microscopic embryonic level, those blood vessels, if you will, are tiny. And so even the smallest hiccup in blood flow through that microscopic placenta can cause difficulties, failed implantation, et cetera, early miscarriage. So Lovenox is something that you might see in your protocol, and that's the reason why. So if you come to us with recurrent pregnancy loss, recurrent pregnancy loss is defined as 3 or more miscarriages typically, but even ongoing biochemical pregnancies, those are another indication where we might involve Lovenox into your protocol. Some of the and then the last one that's used that you might see is injectable form is going to be called Neupogen. And so if you see Neupogen in your protocol, that medication is thought to increase a type of growth factor, essentially, that's found in natural levels to have improved endometrial receptivity. So the inside of the uterus, it's a very intricate dance that tissue goes through to be able to accept an embryo and nourish it as it grows. And so Neupogen is thought to increase something called granulocyte colony stimulating factor. And so in research studies, increased levels of GCSF are shown to have higher endometrial receptivity. And so the idea there with the Neupogen is to increase those levels to help improve endometrial receptivity and to prevent pregnancy loss. Two oral medications that are going to be, you might see in your protocol. One is called Plaquenil, and Plaquenil is another sort of immunosuppressant that helps, again, kind of to prevent the body's own immune system from interfering in the process. And then HCG boosters are another way that we can sort of help to promote the body's ability to positively support implantation. So the endometrial cavity is responsible for sort of swallowing up the embryo and then allowing it to begin the process of implantation and development. And HCG boosters are thought to help improve that process. So those are the bulk of the immune medications. If you don't see these medications in your protocol, I don't want you to panic or worry. Again, we do take pride in individualizing protocols to your specific situation. And so, like we've talked about, your age, your medical history, some of your previous cycle outcomes, those are all different factors that are going to be used to determine whether any of these medications are appropriate for you. And so one thing that I do like to point out is, here at CNY Fertility, we're very interested in sort of breaking out of the mold, thinking outside the box. And so some facilities will say, well, if it's not broken, don't fix it. Or if it's not indicated that there's an immune problem, why would you use immune medications? And our philosophy is a little bit different. And that is that we know immune issues are a common reason for, failed pregnancy outcomes in general, whether that be no implantation or early miscarriage. Those things play a huge factor. And so our thought process is, as long as it's safe, why not try some things out of the box that very well might make for a positive outcome for you? And so I think back to a friend of mine who encountered multiple pregnancy losses. So not only did she have 8, 10, 12-week miscarriages with genetically normal embryos, but even a loss as late as a second trimester. And it basically determined that it was immune issues all along that had played a role. And once things like Neupogen and prednisone and Lovenox and intralipids were involved in the process, we finally had that happy outcome that we had all hoped for from the beginning. So that is kind of protocols in a nutshell, what determines which protocol you will have, and the ability to integrate different medications that maybe weren't brought up, but that you think could be helpful, as long as, again, they're not clinically contraindicated. Then those can usually be integrated into your protocol. So again, if there's no clinical contraindications, then usually we're able to bring those into play. So Christy asks a very interesting question. What do you mean by immune issues? So kind of rewinding a little bit, we know that the immune system is a key player in if you're able to develop and grow a pregnancy to term. So if the immune system fights against the development of the lining or the early pregnancy itself, the body can recognize an embryo as foreign and the immune system can attack it. So overactive immune systems, we know that our immune systems in general are somewhat overactive. We have a lot of environmental triggers, food triggers, and different reasons that our immune systems are overactive. And so we know that by suppressing that overactive immune system, and again, you don't necessarily have to have any signs of an immune issue, but sometimes that is the underlying piece of the puzzle that is preventing a positive outcome from a cycle. So I hope that helps. and it looks like you also asked, Christy, so just so I don't miss this part of the question, so you issue meds over a course of time, like every 8 days. I'm afraid of meds being expired and overload of meds. I would say for the most part, your protocol is going to be issued to you at your either your initial consultation or your follow-up talk. And then we will order all those medications for you. Most of the medications that we use, there are a select few that have a shorter shelf life. But for the most part, these medications are going to have a decent expiration length. And if you're ever worried about the specific expiration dates, that's a great discussion to have with the pharmacy. So when you have your conversation with the pharmacy, you pay for the medications. Not a bad idea to kind of go through each one and make sure that, they're aware of when you're planning to start your cycle, and that based on that date, is there anything they recommend you holding off on having sent out until you get closer to that date. So the medications are typically sort of issued, to use your word, in a bulk in the beginning. And then, if we find that we feel there's a positive benefit of adding something at some point, we certainly would do that. But for the most part, the medications do have decent shelf lives, and wherever you have doubt, definitely check with the pharmacy. Something else that I didn't mention earlier, but I think is important to know, is that many of the medications that you start, especially from the point in which you transfer forward, a lot of those medications are going to be continued well into pregnancy. And medications, some of those medications are ones like estrogen, the progesterones, the prednisone, the Lovenox, the Neupogen. A lot of those medications are going to be continued throughout the first trimester or into the first trimester. So it's always important to kind of understand what medications are going to continue, and to make sure you've got refills on those to make sure that you don't run out. So when we discharge you, once you're pregnant, whether from a fresh or a frozen or an IUI, once you're pregnant, everything is looking good and stable and strong, we're going to discharge you to your OB, your local OB. Everybody starting this process should have an OB. So if you don't, this is notice, go get one, because it doesn't make a whole bunch of sense that you're coming to us to get pregnant, and you're going to need to be discharged to an OB so that OB can care for you. And so it presents a lot of difficulties if you don't have an OB. So, but we will give you discharge instructions to share with your OB that include when each of those medications is going to stop. But I do think it's important to know that sometimes I think people think that, once I'm pregnant, all the medications stop. When in fact, a lot of those medications are kind of they're the medications that are help keeping you pregnant, and are going to help prevent any of those immune issues from sort of getting in the way of a positive ongoing pregnancy. So, all right. So that's everything I kind of had to discuss. I'll go back and answer some questions now. So if you have any questions, feel free to drop those in the comments. But I'm kind of starting from the top. We talked a little bit about why some people get letrozole added into their protocol. If you do have a high estrogen at retrieval, that can be a good indication, Kaylee, to inquire about letrozole. And so there's a number of different reasons that letrozole is or isn't included, but that's kind of one of them. Is if you do have a known high estrogen in previous cycles, oftentimes, especially if that's either caused OHSS or prevented you from doing a fresh transfer when you wanted to, the letrozole can be a good thing to add in that situation. Jesse is asking a good question, and that is, what's the difference between HCG-LH and Menopur? So HCG-LH is there to help grow the follicles and provide that LH support that's needed to have good, healthy eggs result from your retrieval. Menopur actually contains some additional FSH. So the primary difference between the two comes down to somewhat provider specific. So just like if you present to your doctor's office with a particular problem, depending on the doctor you go to, they might have a certain choice of action. So Menopur it does contain that FSH component. So the biggest difference between the two is going to be if you are prescribed, let's say we prescribe 225 of the FSH, primary FSH, which is Gonal or Follistim, and then we prescribe 75 of Menopur. If you do elect, some people will elect to switch over to the HCG/LH because of cost. However, you do have to keep in mind that because there is no FSH component in the low dose HCG LH supplement, we do often have to supplement more Gonal F to make up for that missing FSH. Even then, it sometimes is more cost effective to use HCG/LH, but sometimes people don't respond as well to the low dose HCG, and then we switch over to Menopur. And so those are the primary differences between HCG/LH and Menopur. Let's see here. So, Brandy's saying, concerned about my low dose protocol not working. I'm 35, PCOS, AMH is 4.1, primary infertility. Brandy, we're always going to take your full picture into consideration and give you our best protocol. But please do express your concern. So if you're worried, definitely schedule a follow-up talk with a provider to further discuss. Some people do really well with low-dose protocols and others do not. And as any of you who've spoken with me over the phone have heard me say or even hear, this process is oftentimes as much diagnostic as it is treatment, meaning sometimes we don't know how you will respond until we see how you respond. And so low dose protocol works really, really well for a lot of people and can save a lot of money. In fact, low dose protocols have been shown you can do 2 back-to-back egg retrievals with the same amount. So let's say you're prescribed a high dose protocol. Some patients have shown that you can take that amount, split it into 2 cycles, and end up getting far more eggs in those 2 cycles than you would from one high dose protocol in 1 cycle. So that's a great concern. And, as I said, many clients do wonderfully well with a low dose protocol, but sometimes we don't know until we try. And I get that that's really tough, given the time, the money, all that goes into this. But our providers really do try to individualize your protocol to you specifically, and some sort of those 5 factors that we talked about in the beginning. Christina's asking about best medications or vitamins for frozen embryo transfer. I suppose that's a sort of a whole different discussion, but primarily, as long as you are taking your high quality prenatal vitamins, that's the sort of basic vitamins that we recommend. And then medications are pretty individualized in terms of kind of the history that you're coming to us with. We talked a little bit about this, but Jesse was asking about OHSS. So ovarian hyperstimulation syndrome, that's what OHSS stands for. And it is a process whereby the ovaries are so enlarged from the stimulation itself that the membrane around the ovaries becomes stretched out. So I always give the example, if you put your t-shirt kind of up over your face and you look through it, you see some light, but you don't see a ton. Now, if you stretch your t-shirt, you see a lot more light. The membrane around the ovaries is very similar. So normally the ovaries are very, very small, but as we stimulate them and we grow lots and lots of follicles, that membrane around the ovaries goes from nice and closed to kind of stretched out. So now you can see there's these areas where fluid can sort of leak out of the ovaries. And that is, that fluid goes into places it doesn't belong. So it presses on your bowels, on your stomach, on your liver, on your lungs. It can make it hard to urinate, to breathe, to do a lot of different things. And it can be life-threatening. And so anytime we're worried about OHSS, we're going to advise you to do a couple of things to help mitigate against severe OHSS. So one of those those things is increasing electrolytes. So electrolytes, when you drink electrolytes and your body processes those in your bloodstream, those electrolytes act like magnets to draw fluid back into the bloodstream from places it doesn't belong. So high levels of electrolytes in the bloodstream help to sort of bring that fluid back into the vascular system so that your kidneys can process it, you can urinate it out instead of it hanging out in spots it's not supposed to be and causing those difficulties breathing, nausea from fluid up against your intestines or your stomach. So OHSS is something that really can be managed, but we are very careful to manage it. But it can be life-threatening. If that fluid continues to populate, it continues to develop and go into places it's not supposed to be, it can be life-threatening. So I hope that helped us in terms of a quick explanation of OHSS. Let's see here. We talked about HCG, LH versus Menopur. We talked about LH levels and that those kind of indicate impending ovulation. Brittany is asking, when is HCG used during a transfer? So we kind of briefly mentioned that the two primary times that HCG is used during a transfer are going to be an HCG wash, which typically takes place about 24 to 48 hours before the transfer itself, fresh or frozen. And the idea is that it helps to improve the body's ability to promote implantation. And then also it can be used for HCG boosters. So in a fresh embryo transfer cycle where you ovulated eggs, that HCG in the form of injections can help to help the body support the pregnancy, but also helps the endometrial lining or the endometrial cavity of the uterus to engulf that embryo and help it develop and start the process of implantation. So that's kind of why we use HCG during a transfer cycle. Another reason we might use HCG during a transfer is there is a type of transfer where we want you to develop your own follicle and ovulate. And similar to a stimulation cycle for something like retrieval or IUI, sometimes we use HCG in a transfer to stimulate or to trigger ovulation. And so it's used in that sense as well. All right. Alexander and Esther are kind of asking about transferring 2 embryos at a time. We really try our hardest to help you conceive with one healthy baby. There are a lot of risks that are involved with transferring 2 embryos. And we know that transferring 2 embryos does not necessarily double your chances of conception, but more often just doubles the chances that if you do conceive, that it will be with multiples. The primary reason behind transferring more than 1 embryo at a time is to mitigate against factors that would cause the embryo to fail, primarily older reproductive age. So the American Society for Reproductive Medicine has established guidelines that we do follow that say, based on reproductive age, the age of the embryos, and the quality of the embryos, what this safe number of embryos to transfer is. Because we do know that multiple pregnancies does increase the risk of the pregnancy itself, increased risks of miscarriage, preterm labor, preterm delivery, complications in the babies. So there's a lot of different things at play. And our goal is to always keep you safe. And so while we can always discuss transferring 2 embryos at a time, we do adhere as closely as possible to those guidelines to make sure that we are safe. So let's see here. Other questions. Let's see here. We talked about your question with no letrozole, so that's good. Oh, this is a great question, Adelia. I'm planning for 3 months of priming with Omnitrope and LDN. How long will one vial of Omnitrope last? So one vial of Omnitrope, if you're taking 6 units a day for priming, is going to typically last you about, I believe it's about 18 days. So obviously if you're using 3 units, it's going to last you more closer to a little over a month. But usually it's about 18 days that vial of Omnitrope is going to last. Mallory asked a great question about the role of birth control in the process. So as a general rule, we do not use birth control for everyone. That is a standard part of some procedures at other clinics. But as a general rule, we use birth control primarily to time cycles. So we know that traveling creates a lot of unknowns. And so some people really want to nail down their retrieval to happen during a certain week of a certain month. And so we can use birth control to time that cycle out to make sure that, or to try to get that retrieval or whatever procedure to fall during that specified time frame. Another reason we use birth control is sometimes we use it to put a pause on your cycle. So every now and then, we might be full for retrievals in one of our offices. So Syracuse is the most common location that's kind of over full. And so if for one reason or another you must go to Syracuse, we can use birth control to sort of pause your cycle until there is an opening. Even if that's 2, 3, 4 days, we can use it to sort of place that pause button such that when we stop it, we can sort of pick up where we left off and go from there. Another reason some people use birth control is if in a prior attempt you had really a vast difference between follicle sizes. So let's say we had a group of follicles that were in one size range, and then another group that were in a totally different size range. Some people will use birth control pills to sort of synchronize all those follicles so that once we start the stimulation, they all grow as a group so that there aren't those vastly different follicle sizes. But we do not routinely use birth control for all cycles. So individual reasons why that may or may not be used. Let's see here. What other questions do we have? We are running out of time, but let's see. Well, this is a very common question. So Jamie Lynn is asking, how soon after, I'm assuming you mean consultation, how long after consultation do you get your protocol? It is usually between 2 and 3 weeks. So we know that's a long wait. And what we try to do to help sort of lessen the pain of that wait, because let's face it, any of you watching tonight, any of you who are with us have been wanting to be pregnant and have a baby long before you got here. And so we know that 2 to 3 weeks is a long time to wait. But what we try to do to help ease that 2 to 3 week wait is to upload to your patient portal. It's usually within 1 to 2 days of your consultation itself. We try to upload some informational packets and some lab orders for things for you to read, learn about, paperwork for you to sign, and preconception lab testing for you to do during that 2 to 3 week wait. So we do know that it's a long time. If you have waited your 2 to 3 weeks and you still haven't heard from us, you are welcome to check in to see kind of when we estimate based on those who are waiting. We can sort of estimate when you may be getting a call. But unfortunately, we do know that there are many different reasons why many of us need to get started right now, but we really do try to be fair and balanced in our approach to calling consultations in the order in which they were completed. And so the one exception to that is any of our clients with a cancer diagnosis who are trying to preserve eggs or embryos now, those clients are always going to move to the top of the list. But as a general rule, we really do try to be fair in our approach to make sure that everybody sort of has their chance in line, and we do follow that. Ingrid, this is a really good question. I did not touch upon the antihistamine protocol, but it's absolutely okay to take the antihistamine protocol during priming, as long as you don't have any contraindications, medical reasons why you shouldn't be using the antihistamines. Those are going to be Benadryl, Claritin, and Pepcid. They're all over the counter. And there's no reason why you cannot prime with those during that whole month before you stimulate. And then you said about a month before stimming. Yes, that's generally correct. Most people will prime for about 30 days, but some people, we do recommend a 60 or 90-day priming cycle, just depending on your kind of your unique situation. Jessica, this is a great question. What priming medications are there for men besides vitamins? The two primary medications that you might see prescribed for our male patients are going to be LDN, which again, that's that immune system medication, helps kind of balance everything out, lowers inflammatory levels. And then every now and then I'll see male patients prescribed HCG injections for the month or two leading up to retrieval if count is a real problem. And even Clomid is used oftentimes. I don't know if I'd call it I guess it works as a priming medication, but I hope that answers your question, those are the sort of prescription medications that could be used for our male patients. Okay, because we are really running out of time here, let's take a couple of more questions. So Key is asking, 35 years old, history of recurring miscarriages. I'm so sorry to hear that. That is such an awful place to be when you're able to get pregnant, but then you have difficulty sustaining that pregnancy. There's, so much that goes into just getting to that point. And so it's absolutely devastating to have those losses. And so I am so very sorry. Your consultation is June 10th. Yeah, I'm going to say you're probably right. I think you're probably looking at Immune 3 or Immune 4. And as we kind of mentioned briefly earlier, a lot of those immune medications are continued into pregnancy. So things like Neupogen, Lovenox, those medications are continued well into the pregnancy to help your specific situation, which is, okay, now I'm pregnant. Great. I need to stay pregnant. And so I would say, obviously depends on your unique situation, but I would say it's probably fair to assume that we will prescribe Immune 3 or Immune 4. Brittany, this is a good question. Transfer baseline is tomorrow. Okay, I thought you were saying that your transfer was tomorrow. So is it too late to test for natural killer cells and immune issues? No, well, potentially. So if your transfer baseline is tomorrow, you're looking at a transfer then approximately 2 weeks from tomorrow. A lot of the immune testing does take some time. It's in-depth testing. It's not something that anyone can really do stat necessarily. So I think it's certainly something you should discuss with your nurse tomorrow. If that's something you've heard tonight and it sparked that you're really hoping to flesh that out, then it might be worth postponing for a month to have that testing. But there again, as long as it's not medically contraindicated, there are a fair amount of the immune medications that we can incorporate in the absence of that testing. And also it's important to consider that immune testing could come back completely normal, and there could still be subclinical underlying reasons to support the use of some of those immune medications. So I hope that helps kind of answer that question for you. But if in doubt and you're not going to postpone the transfer, I would highly recommend just discuss that with your nurse tomorrow when she calls to give you your instructions, and we can kind of talk through what may be appropriate in your situation. Okay, let's take one final question. Brittany, I just answered yours, so I hope that was helpful. Let's see here. Let's go. Since this was kind of all about stimulation protocols and whatnot, Ebony, I'll end with your question. So your question is, what is the minimum and maximum amount of time for stimulation? So that's such a great question, because the stimulation time frame does vary greatly depending on the person. So while we always say that the average amount of stimulation or average amount of days is around 10, I have seen people who are amazingly ready to trigger on stimulation day 6. That's pretty uncommon. Usually earliest is around day 7. And then the longest or the maximum amount of time, that's debatable. But I would say as long as there is good, steady follicular development, you could look at stimulating for as much as a month. Now, that would be a very, very unlikely scenario. I would say most likely is somewhere between 7 to 12 days, and then outlier could be as soon as day 6, could be as late as day, 13, 14, 15. And then, worst case scenario, I have seen people stimulate for a very long time, but that's certainly not the norm. So I would say the average minimum to maximum is probably somewhere between 7 to 13 days. So I hope that narrows it down. All right, friends, it has been a wonderful hour. I hope you all have found this very helpful. Be sure to reach out through your patient portal if you have specific questions about your own specific protocol. Like I said before, as long as it's not clinically contraindicated, meaning there is some clear reason that it would not be safe for you to use any of the medications that we have talked about tonight, for the most part, we can discuss adding additional medications into your protocol. So never hesitate to ask. We're always here for you through your patient portal, through the patient portal, specifically the messaging feature. Be sure that if you are a travel patient, that you always direct your questions directly to Global Travel, as if you're coming to Buffalo for your retrieval, you might think, oh, let me send the Buffalo nurses my question. But ultimately, the Global Travel team tries to handle all cycles until you step foot in one of our offices, just for consistency. And so your message will be forwarded from Buffalo to the travel team, and that can cause a delay. So just be sure if you do have specific questions that you direct those to the travel team. I will not be here with you next Monday night, as it is Memorial Day. So we will come live again on June 7th. And I'm very excited to have a guest on June 7th who will be representing our Global Travel Concierge team, or our Global Connect team. That's the amazing, amazing group of nurses that answer the phone lines. They're your clinical team. And Amanda from the clinical team will be joining us. And we're just going to talk about all the ways that the travel team works directly with the Global Connect team to help support you through the course of your cycle. So I hope everybody will join me June 7th for that. And until then, I hope everybody has a safe and wonderful week, a safe Memorial Day, and we'll see you in June.